Let's understand the pelvic or parasacral approaches. Here, the sciatic nerve is targeted as it exits the greater sciatic foramen and lies under the piriformis muscle. This is called as the parasacral sciatic approach, and functionally it is a sacral plexus block. It can be performed using PNS guidance via Mansour's or modified Mansour's approach, or ultrasound guidance, which includes direct block involving Benston's, Casal's and Taha's approaches, or indirect block in the form of parasacral ischial plane block, which is also known as PIP block. Mansour's approach was the first described PNS guided parasacral technique. In this method, a point is marked on the posterior superior iliac spine and another point is marked on the ischial tuberosity, with the patient either in prone or lateral position. A line is drawn connecting these two landmarks. The needle is inserted perpendicular to all planes at a point 6 cm distal to the posterior superior iliac spine along this line. In modified Mansour's approach, the same line between the posterior superior iliac spine and ischial tuberosity is divided into three equal parts. The needle entry point is then marked as a junction between the proximal 1/3 and distal 2/3 of this line. The success rate with the modified approach is often higher due to better targeting of the nerve. During needle advancements in both the techniques, you may initially encounter gluteal muscle twitches. If there is a contraction of the gluteal muscle in the outer quadrant, it indicates superior gluteal nerve stimulation. Since superior gluteal nerve lies superolateral to the sciatic nerve, you should redirect the needle inferomedially. If the medial gluteal contraction is seen, it suggests inferior gluteal nerve stimulation. As inferior gluteal nerve lies inferomedial to the sciatic nerve, you should redirect the needle superolaterally. If the inferior gluteal nerve is stimulated, that's a good sign. It means you are on the correct trajectory. From that point, sciatic nerve can usually be located within 2 mm of further needle advancement. Deeper advancement may sometimes cause piriformis muscle twitches at higher current thresholds. Once the needle enters beneath the piriformis, it may stimulate nearby nerves such as superior gluteal nerve, nerve to quadratus femoris, obturator nerve, or the pudendal nerve. This can result in responses like perianal contraction, paresthesia, or thigh adduction. In the same plane, appropriate sciatic nerve stimulation can also be elicited. Occasionally, the needle may contact bone, which serve as a useful depth marker. As a safety rule, the needle should not be advanced more than 2 cm beyond the point of bony contact to avoid risk of injuring pelvic viscera.
Posterior superior iliac spine and the ischial tuberosity. Okay, I have already given some local. So one more important safety feature is I keep it open to the air. Now I'm going absolutely perpendicular to the skin. Increase it to 1.5. Just perpendicular to the skin. So I'm going in. So this is the gluteus contraction. So I'm in the right track. I'll go inside. There we go. You can see the twitches, dorsiflexion mainly. You decrease the current. Yes, decrease it slowly. Yes, yes. It's still coming at 0.5, 0.4. Decrease it up to 0.2. Okay, 0.2. Is it coming? No, it is not coming. So I'm not my needle is not intramural. Decrease it up to 0.4. Yes, we can see the dorsiflexion. Yes, at this level, dorsiflexion is also accepted response. So I will go for the injection. So it's still coming. On aspiration it is negative. So the moment I will inject 1 cc of local anesthetic, there will be no contraction anymore. So that is positive Raj sign. Show there. Okay, I have injected almost 10 cc. So if you give good amount of local anesthetic, you can see the backflow also. We will check every 3 to 5 cc you have to aspirate and then inject.
Let's understand the ultrasound-guided parasacral approach. In Benston approach, the key landmarks are posterior superior iliac spine and the greater trochanter. A line is drawn connecting these 2 points. The midpoint of this line is identified and the ultrasound probe is placed over the medial half of this line. At this starting point, you will see a hyperechoic line of the underlying ilium. and gluteal muscles appears above this line. From here, the probe is moved caudally and medially, maintaining alignment parallel to the original PSIS to GT line. That's why this technique is also referred to as parasacral parallel shift. As you continue shifting the probe, you will observe break in the continuity of the initial hyperechoic line. This marks the sciatic notch. At this level, the sciatic nerve appears as a long hyperechoic oval or band-shaped structure under the hypoechoic piriformis muscle and above the hyperechoic posterior border of the ischium. In this view, the probe is aligned along the long axis of the sciatic nerve, providing an optimal long axis view of the nerve. The needle is inserted either in plane or out of plane, targeting the nerve and depositing local anesthetic below the piriformis within the subparaneural space. In parasacral ischial plane block or PIP block, instead of directly targeting the sciatic nerve, if the ischial bone is contacted, the drug is deposited on its surface. It can still lead to effective sciatic nerve block via indirect spread. This is known as parasacral ischial plane block, an indirect ultrasound-guided approach.
But always use the dual guidance technique. Here you can stimulate with the 0.5 or 0.4 milliamps current and you will get the appropriate response once you rule out the intraneural placement, and then you can deposit the drug. So after negative aspiration for the blood. As you can see, post block scanning, a nice drug spread on both sides of the sciatic nerve in longitudinal field.
In Casal's approach, two bony landmarks are identified: posterior superior iliac spine and sacral hiatus. A line is drawn connecting both the points. Then another line of equal length is drawn perpendicular from the midpoint of the first line. The ultrasound probe is placed at the tip of this line, oriented parallel to the first line. In this position, you will see a continuous hyperechoic bony line with the ilium on the upper part and ischium below. Above this line, the sciatic nerve appears as another hyperechoic structure lying deep to the hypoechoic piriformis and gluteal muscles. Local anesthetic is deposited around the sciatic nerve above the ischium below the piriformis. You may also visualize pulsating inferior gluteal artery medial to the sciatic nerve, which can be confirmed using color Doppler.
Casal's approach, one first line is drawn between the posterior superior iliac spine and the sacral hiatus, and a perpendicular of similar length is drawn at the midpoint between these two lines. So that will be the landmark for the point of for the needle entry. This approach can be used for PNS guided or as well as the ultrasound guided or the dual guidance technique. As you can see, directly when you will keep the probe over that point, you will get the view of the sacral plexus with the sciatic nerve. With the caudal rotation of the probe, you will get a longitudinal view.
In Taha's approach, no bony landmarks are used. Instead, the probe is placed at a point approximately 8 cm lateral to the upper end of the gluteal cleft. Here, the sciatic nerve can often be visualized in short axis, positioned medial to the posterior border of the ischium. If the sciatic nerve is not visible initially, the probe is moved cranially until the flat hyperechoic line of the ilium is seen. Then probe is swept caudally, watching for the break in the continuity of the line. This indicates you have reached the greater sciatic notch. At this point, a slight caudal tilt of the probe helps to visualize the sciatic nerve as a hyperechoic oval structure deep to the hypoechoic muscle between the two hyperechoic bony lines, ischium laterally and sacrum medially. Local anesthetic is deposited subparaneurally around the sciatic nerve in the real time. To summarize the key landmark for each parasacral technique, for Benston and PIP blocks, the landmarks are posterior superior iliac spine and greater trochanter, and probe is kept on the medial half of the connecting line and moved caudally and medially. For Casal's approach, the landmarks are posterior superior iliac spine and sacral hiatus. A second perpendicular line is drawn from the midpoint and probe is kept at the tip of that line parallel to the first line. In Taha's approach, there are no surface landmarks. The probe is placed 8 cm lateral to the upper end of the gluteal cleft. It is moved cranially until the ilium is seen. and then swept caudally. A break in the continuity confirms the greater sciatic notch, and slight caudal tilt helps to visualize the sciatic nerve.